That done, sir.
Yeah. Now we are live. So normally wait for 50 students. So 5 minutes maximum. 2 minutes we get it that. So we'll go for. So shall we start, sir? 43, 44 it will change, and maybe sometimes we can, if you one.
It's your decision. Yeah, Nalini, with you, whatever you plan.
So good evening, all of you. And this today is for this NOEL session. We know it is weekly training session for all neonatal trainees. And today's in session, the program we are running today in this session of 6th session of neurology section and 14th session of this 4th edition of NOEL session. That's the 14th session today. So with this actual session, we changed from neurology to neurodevelopmental follow. And when I am thinking neurodevelopmental follow, I cannot imagine any person other than Naveen Jain sir, who is for last so many years, 15 years, has taught across the country all the, when I was being trained also in neonatology, I learned the developmental follow program from sir only. So last 15 years, so many national conferences, workshop, is the leading faculty and taught all of us, a generation, about the importance of identifying high risk neonates and what are the basic follow up we should do to optimize their better care later. So we make it protocolized. When randomly people were doing, making it protocolized, making it follow protocol, distributing to across many of the centers, sharing freely. When the people charge for a training, he always said the all the documents freely and taught all of us. So I'm known it for introduction. Dr. Naveen Jain sir, in the neonatology students, all you know him. And today's session, it is beyond the student presentation. We came a faculty presentation here. So sir, in the next few minutes, 30 minutes or 40 minutes, I am expecting sir to introduce the importance of neonatal follow-up, particularly specifically if a baby is at risk, or we commonly say high risk. In those particular babies, what should be our target follow, and how to make the follow-up successful, and how to do it. What is the process of doing it? Probably we'll learn from sir in the next few minutes. So, sir, this now the stage is yours, sir. So you can guide us, including me. You can guide further how to optimize the care and the follow-up of this high-risk baby, sir.
Thank you, Nalini. And many leaders in the making. We really have had a 20 years journey when fellowship programs have become a reality in our country. Really, there is a divide sometimes when people wonder whether a 1 year fellowship is sufficient to train neonatologists, but I am of a strong belief that these 100+ fellows who we are training in NNF, similar number in IAP and universities, are the ones who are serving the country. You are going to places where newborn care is not being offered, and every small thing that you do differently than what was happening is a service to community. So lot of intensive care we do, and even if you're not neonatologists, even if you are not a doctor, if you see a child who cannot enjoy his life like another child, who cannot run normally, who struggles in school, who is wearing a very thick glasses, who is hearing impaired, who has some difficulty in each subject and is spanked by the teachers and by this one, is a pain. It's very sad. We all feel terrible. I can't give you a proportion, but some of these are probably not immediately correctable. There may be genetic problems, metabolic diseases, which may be get recognized, still not repaired. But a large proportion of these are modifiable. And through some small stories for 10, 15 minutes that made me learn, Nalini learn, we all learn through mistakes. Hopefully you will repair and not repeat the same mistakes and not have a family or baby struggle. We all want to do the right thing. So the first foundation stone for a similar concept of structured follow-up happened in 2006 or 7, when we had a state conference in Trivandrum, and we wanted to have this kind of a workshop. And people were very amazed, what will you do in this workshop? So we just had one paper which had 10 points written down, where we thought that if these 10 points we focus, we can prevent disability in a child. And that was under the glass top of our tables. Every time a baby who came to the OPD, before they left, I would ask them to wait. I want to check whether thyroid function has been done, whether hearing has been assessed, whether the baby needs a visual assessment, maybe refraction, whether the baby has his hips in place, and is the child playing like other children, is not at risk of autism, and so on. So there were a few 10 or 15 correctable risk factors like growth, head circumference monitoring. Gradually, this list started growing like we all have learned across the journey. So in the next 15 minutes, and maybe a little bit more than that, we will just share the Blue Book. Many of you are already using the Blue Book in different versions, and that's very happy to note. So if you're already having a version of this Blue Book, you may just learn together once again how this Blue Book happened and what is this Blue Book and what we can do. Let me just come back. I'm wondering why I'm not seeing the Blue Book on. Just one second. Yes. Nalini, are you seeing the Blue Book?
Sir, is clearly visible, sir.
Right. So,
Front page, sir.
yeah.
So the front page.
So you may have a structured follow-up module which is similar or different in your unit. And we will run through about 15 pages of this book. We won't cover everything. And we will surely stop at something like 8:35 and allow you to ask questions. This Blue Book goes to the bedside of a baby as soon as he is admitted to the NICU. The very next morning, our follow-up team, there are two development therapists. They take rounds in the NICU. If there is a new admission, they would just place this book under the baby's bedside. There are some portions which we doctors fill and some they help us. But you can see the gestation and birth weight we know is one of the most important risk factors. And some antenatal factors can determine outcome. For example, if it was a monochorionic twin and other twin had died, there are some risk factors. If it is abruptio placentae, if there is a mother who has had severe placental insufficiency, these may all affect the outcome. So such antenatal steroids given and not given, magnesium sulfate given or not, these things, unless they're listed here, they will get forgotten afterwards. Babies do look very same when they come to your follow-up service. In the newborn problems, we would again list out major diagnosis and interventions like did the baby have bronchopulmonary dysplasia? Did he have a hemodynamically significant PDA? Did the baby receive DART therapy? All these can affect the outcome of the baby. This is one of the most important activity to be done while the baby is being managed in real time. It is no special intelligence to understand that a baby who is at 30 weeks at birth or less has higher risk than development than a baby who is older in gestation. And same with the weight. And if baby is fetally growth restricted has higher risk. These are the factors as students you must ask in a development follow-up case. Did the mother have eclampsia and develop seizures? Were they monochorionic twins, same gender twins, at least you must find. Triplets or more will add risk factors. Did the mother have clinical signs of chorioamnionitis, uterine tenderness, fever, tachycardia, and high counts? Was the baby delivered urgently because of cord prolapse? Abruptio placenta is abdominal pain and blood loss and emergency delivery, and absent gastric flow. So these are some risk factors. No antenatal steroids, extensive need for resuscitation, ventilation with hypocarbia, prolonged ventilation, air leaks, shock requiring inotropes, steroids given for shock therapy or inotropes, symptomatic hypoglycemia with jitteriness, seizures, encephalopathy, prolonged hypoglycemia, severe hypoglycemia, and ultrasound showing either ventriculomegaly or periventricular leukomalacia, infection affecting the brain, abnormal high bilirubins with encephalopathy or requiring exchange transfusions, and a delayed treatment for hypothyroidism for some reason. Now, these are things we all know. So what we learned is that the baby is same. He may have different medical problems. As you tick and circle these medical problems, it is not difficult for parents or for doctors to understand that if there are more circles in the red, the right side, then the risk and the need to follow becomes more important. It's a visual display for parents, for us. When these babies come even at 6 months of age to my OPD, I will open the page first and look at the risk factors because I would have forgotten many things. And the presence of these risk factors allows me to assess this baby. In fact, there is one more part here. You can see extramural or intramural, which allows me to subtly even discuss with the family when I start talking about the baby's care afterwards. If the baby is born outside, then I know that we were not knowing or having control of many of the medical factors that have happened to the baby. So the first message for fellows who are in the meeting today is that we need to have a real time, once in a week at least you allot for your unit to circle the risk factors and their severity also. A baby who has hypoglycemia without symptoms, just a value of 35 is different than a baby who had hypoglycemia, became encephalopathic, seizures, jitteriness, and this makes all the difference in assigning risk. So a baby who, when Dr. Radhika, who is our first DNB trainee, she is now heading the unit at Government Medical College Trivandrum as professor. This was her original research, and what she found that among 250 babies who are born at less than 33 weeks, only 12% would fall into high risk category. They needed to come back for follow-up. Their risk of disability was 20%. Whereas babies who had a lower score, 88% could go back to community and be referred only if the pediatrician had a concern. Their disability rate was only 4%. And therefore, burden on the system can be reduced. Also that it will reduce the chance of missing babies who need closer follow-up. Parents can understand. They ask, why is my baby at higher risk, doctor? Again, an underutilized tool is the growth chart. All students would know that the growth chart is different if you are having a small head versus a small length. The Dine's formula was old, but the concept of Dine's formula is very important. In Trivandrum, we get patients from Maldives. They are small structured. Even Kerala people and generally people below the equator are from a smaller race compared to people who are from Punjab, Kashmir, North India. They are from the Aryan race and they are taller. They will have bigger heads generally. So it is not the absolute value of head circumference. If you have the head circumference on 50th centile and the length on 90th centile is way to be smaller. A baby who has head on the 3rd centile and length also 3rd centile may not be as worrying as a baby who has only head which is smaller. Or similarly, serial measurement of head circumference over the time makes all the difference. So that is called head growth failure. For students, in Canada, there is a very useful study to look at antenatal steroids and its benefit or not. And those babies who had head growth failure, they had bad outcome. Those who had normal tracking of head circumference in an ICU had good outcome. So this is a very useful tool. It should be plotted. You may use a different chart, but Fenton's is a popular chart. It can be gender specific, girl or boys. Okay. Now we have this column we have added recently is early intervention in ICU. All your developmental people should be in the unit as a part of not nurses, doctors. There's a developmental person also in the unit. He is doing rounds every day, services every day. We'll come to it. What is it? Now, despite of this vision coming to us, a thought coming to us in 2003, our compliance by our team was close to 5 to 6%. We used to forget to plot head circumference risk factors. And I asked my teacher, Dr. Shabrinath, why is this happening? Are they not interested in what I'm trying to teach them? He said, did you write it down? Did you actually tell them that this is what I want you to do? Management principle is first write down and tell what you want. And 90% people would follow it. So we then wrote down a protocol. On day one, you must talk to the parents and tell them that you are a part of the service, early parent participation program. We record the medical risk factors antenatally known that till that far resuscitation details, and we ask for breast milk on first hour. So immediately after that baby is stabilized in the ICU, intubated, surfactant given, then the resident walks over to the labor room, meets the mother, shows a photograph and video of the baby. The labor room has stocked the breast pumps in the labor room, and then they start asking the mother to start pumping milk. She doesn't get enough milk on day one, but if she does this way, by day two, day three, she can give enough milk. We know the power of breast milk in improving developmental outcomes. Now, despite of this checklist, our compliance is about 60 to 70%. But you can imagine if the checklist was not there, it would drop still lower. On day 3 to day 7, we remind ourselves how sick baby is, we would send the first thyroid screening sample. We would record the first head circumference. In the absence of such a checklist, the first head circumference is recorded 4 months of age when the baby starts developing developmental problems. There is no serial trending value available to you. Once again, we are reminding ourselves to record new risk factors. If hypoglycemia happened, hypocarbia happened, baby is still intubated, early stimulation would start. We are asking the parents to come touch the baby, start talking to the baby, even if the baby is intubated. Today morning, we spoke to a mother in the NICU, 27 weeks, 850 gram, or we went to the mother and said, will you please come and give the tube feed by yourself? Who do you think the baby will be happy if you give tube feed or the nurse gives? She didn't say, I'm tired anymore. She was willing to walk to an ICU post LSCS on day 3. And you can imagine the phenomenal benefit in improving breast milk output. What is the point in looking at the position of baby, which is related to transient tone abnormalities after 15 days? It should be starting from immediate period. So infant position assessment tool is a reminder to ourselves to confess, despite of this reminder there, and residents may just tick it. If I ask them what is this tool, half of them may not know. But other half at least know. Ticking has improved, some improvement in our service has happened. By 1 to 2 weeks of life, we do the first neurosonogram. Your protocol may be different. You may be wanting to do a day 1, that you may adopt according to your program, but have it there that first neurosonogram must be done before 2 weeks of life. We repeat a second thyroid screen in our unit by second week. And again, if the baby has become better, we are starting to do kangaroo mother care, non-nutritive sucking, oromotor stimulation, and other early intervention teams. By second to third week, if it's an AROP baby, we would do ROP check. Again, mark head circumference, a reminder again. At the end of 1 month, more things would happen and it would go on. The certain labs are done with relevance to development follow-up, like thyroid screen. Here we have written down the values in the footnote because we noticed that babies used to get discharged and get treatments for values which did not warrant treatment for thyroid function. So therefore, we put down the values which are trigger points for treatment so that even if they go away from the unit, and many times babies used to come from other units for follow-up, they will have bundle of files like this. One is an ultrasound report, one is an ROP report, one is a thyroid report, and you keep flipping to pages and an important message gets missed. But if you have noted them down in a structured page like this, then you would immediately know and you can write in different color. A red pen can be used to mark something that is abnormal. Before discharge, you would have a clear checklist. Does the baby have an active medical problem? Is he still difficult to feed? Is he having bronchopulmonary dysplasia going home on oxygen? A reminder again that breast milk is important. You would not only, we used to write weight and people used to just tick. Now we are writing whether weight is tracking. I will ask this question and you can answer in the chat box that if weight is not tracking, which disability risk is very, very high if a baby is having poor weight growth. I'll give clue also. You will know, you would have heard something called Winrock. So if head circumference is tracking or not, it's not enough to plot. Is the head circumference going on the, is physical examination pointing to an IU marker, to a chromosomal anomaly? Is there a hip abnormality? Did you do the ROP check or did you tell them the date? Did you do a hearing screen or did you appoint? Did you follow the thyroid function, do neurosonogram? And a neurological examination before discharge is very important. Today, we won't have time for that, but we'll just show you how easy it is to do neurological examination in newborn in a structured way. It is combined with medical follow-up. Neurology is not different. So immunization is also important. Early intervention, this is very critical. Are the parents coping well? They've gone through so much stress because their positive energy is what decides development of the baby. and did they attend all the pre-discharge counseling sessions or not. We have a clear list of examination also before discharge, which you can just tick: IU marker, hepatosplenomegaly. These things get forgotten before the baby gets home. Here, this room numbers would change for you. Please adapt this. Somebody asked me, would you get this book? Yes, that is our intention. We want you to use this book. We want you to change the first page from Kim's Health or from Rainbow Hospitals and make it your own. There's nothing that is our original in this. It's all borrowed from places. It is just management to improve compliances. But you will only have to change the page numbers to room number. Parents should know where to report. It should be easy for them. And we also have an approximate costing to be listed if you are a pay from pocket hospital. This is the Hammersmith neurological examination which I was talking about. We may not get detailed time to discuss this, but it has domains like posture of the baby and tone, and very easy to do. You don't have to take any classes. One teaching session and residents can do it well. So you can just mark an HIE baby or a preterm baby who has become term gestational age, and you can plot and be able to do tone patterns, reflexes, movement assessment index, which is borrowed from general movement assessment, and visual auditory orientation to make sure that you remember that development is not only about tone, it's about vision, it's about hearing, it is about mentation of the baby, how easy it is to arouse and console the baby, and so on. So this is a very useful tool with very high negative predictive value. A baby who has a normal examination has very low risk of disability. We have a hearing assessment page, which not only tells you that you need to do hearing assessment like OE and BERA, it even has instructions for parents so that they know why are they undergoing tests. Many times parents do not know why to do a BERA, why the baby should spend 1 hour in the audiology lab. You could convert this into regional languages so that parents can read it. This book goes home with the parents. Same with ROP screening. There is a clear message to parents why we need to do ROP check, what is the schedule. And you can see that it is not only about ROP, it talks about squint, about refraction, whether you would need later on other things, and even cortical visual function. These are also listed. There is ROP screening form. Our retina person marks the observations on this so that it is a medical legal document very safely with the baby. Neuro behavior assessment is done. It is marked in the book. And later on, the baby's development follow-up starts at 4 months of corrected age. Many times parents get confused that the baby is already 4 months old and is not doing what other family children are doing. So we can remind them that, look, the date you have put here says 4 months, but it is now your baby is already 6.5 months old. It is because you were born at 24 weeks. And only now your brain has become 4 months from the expected date. Not only you do assessment like Amile Tyson, you make a commitment whether it is hyper or hypotonia. Is there asymmetry? So it is like functional commitment that finally what is there, is it good or bad? And same thing at various gestations of 8 months, 12 months. These numbers can be modified to 3, 6, 9. That is up to your personal program. And if the baby has not done well on that particular age, you can call them more frequently also. At 18 months, you can see you must have clearly decided whether autism risk is there. It can start after 9 months of age. And then there's something kind of a list we are having. Are you having motor problems, hearing, vision problems, cognitive problems, language? And is there a chronic medical problem? Because these will also influence the developmental outcome. This doesn't stop there. At 2 years, you will have language evaluation, social adaptation. At 3 years, you also have a report from the teacher, because finally it's not about Bailey scales course. It is about the school teacher finding whether this child, and TABC's behavior checklist. 4 years, you would have again behavior checklist, and now formal assessment of IQ can start. At 5 years, you would also have, and each time you can see annually there is a refraction assessment. This goes on till 6 years, till the child enters first standard, first formal school. And here you can see we have a checklist which is not having dates assigned up there. These dates can be filled because sometimes you would be calling them more frequently than 4, 8, 12 months. Then the development specialist can ask them to come a little earlier. We use a very simple tool called CDC grading. It's very fast to do. It can be done in 5 minutes. And you can do a Denver screening. People may say it was not designed for high risk, but I can also do that in my OPD. If my parents don't have time or my specialist is not there, in specific situations, we may ask either as a part of research protocol follow-up or very high-risk babies, you want to do fine-tuning, you can do a Bailey scale also. So, but the point what you have to is this part, which is the last part, is the interpretation. No point in doing this tool. You have to interpret in 3 ways. Today, your baby is normal. I'm not doing new investigation or interpretation or intervention. Today, your baby is having a problem, then there is no follow-up. You start referral to a neurologist, to an orthopedician, to an MRI room, whatever it may be. Or I'm not able to decide, can I see you after 2 weeks to 4 weeks? In that period, can you start doing some early intervention at home? So you must, the whole purpose of all follow-up is timely referral to the right people if required. So you must mention there is referral, and most specialists are too special. They would not be interested in the baby like you are. They will give some information which parents don't understand. They don't have the same empathy that you have. So they come back and the feedback from specialist is entered by you and explained to the parents clearly. So this form is there. And you can see this goes on for different years. And here is the interpretation. Normal on day of assessment, because parents often ask, today my baby is normal. Is that the end of follow-up? You say today he is normal, but that is not the end of follow-up. You must continue to follow because tomorrow the brain is going to do more complex things. And therefore, continuation of follow-up is necessary. You have the charts which are there, which you can use. Growth charts for older children. You can use an IAP chart. You can use a WHO chart. You can use even the modern charts which are there from the other groups like this one. Doesn't matter which you're using, but the point what you have to do, intergrowth charts, but you have to find tracking of growth, head circumference, weight. Poor weight gain is also maybe a pointer to neurological problems. There are other things you can add to the growth chart. Now you can see some medical problems are also important part of follow-up. It's not only about neurodevelopment. Follow-up means some babies can develop with thrush. A new murmur may appear, which is not there. Liver and spleen may grow. You might have injured the baby, an injection site abscess may happen, constipation, hemangiomas, hernias, undescended testis. These are common problems in babies which for surface later on and they must be examined. Other factors which may affect outcome are need for transfusion, continuation of medication, and so on. Vaccination book is on the same book, so that wherever they go for vaccination, when they come to my OPD, the first thing is they don't have the same pink color, small, simple book which other parents are having. I know that this baby was in an ICU. He needs to be looked at differently. And so if they go to vaccination, even to a facility where they're not having specialist follow-up, they will not get missed. Now I go back to the last page before I wind up my presentation. Is the first page is important is that even obstetric factors are recorded here. The high risk obstetrician or the obstetrician is also recording risk factors. And there is an important aspect which as young people you may not pay attention to is the parental education, where they stay, are they nearby or far away, who are the primary care persons you are going to refer the baby to. All babies cannot come back to Hyderabad or Trivandrum. So you may want to refer them to a primary care person. They are also listed there and how they can reach out to you. So I'm not going to cover all the tools. What I wanted to show you is that it is the right of the patient. It is a duty. MKC sir used to show one slide in the beginning. He's my guru. Is that a pediatrician is differentiated from a general person because he measures growth and development. That is how a child is different from an adult. And if you're not measuring growth and development, you're not a pediatrician. You have not done your duty. If you plot the head circumference, if you just ask 4 milestones, head control at 4 months, sitting at 8 months, standing at 12 months, can your child see and hear? At least this much if you ask, your duty is completed. At least you will make sure major delays in referral to right people has not happened. So with this, I would conclude the one-way presentation and you can ask questions. And this PDF will be shared. There is no copyright. You do not have to acknowledge our institution. You can change the first page of our institution or wherever it says KIMS Health to your own. But please make sure to adapt it to your program. If you're not doing thyroid functions twice, make it once, because whatever you write is required to be compliant by a unit, becomes a medical legal document. So please make sure merely filling the form saves you from medical legal cases. Thank you, Nalli, and thank you, students. Back to you.
Thank you, sir. Thank you for an excellent session with like a primer for the developmental follow what required in ICU and beyond. It is the ICU, definitely the ICU follow is more important for the during the intensive care. Once it is over, the baby stabilized. But equally more important when the baby goes to home environment, exposed to the home environment, taken care by the parents. That's time at regular interval to recheck again baby's condition. It's our only responsibility. It is not responsibility by any other physician. The care we provided during the intensive care we stabilize the baby survival after, the intact survival to ensure it and to recheck so that to optimize, it's our responsibility. That's the basic thing we have to understand as a pediatrician. We cannot give the responsibility to others. If we have taken the commitment, we have initial commitment that we are taking care of a small baby, a fragile baby, a newborn baby in our ICU, whose life we saved. Equally, we should commit. That's the message I got from you, sir. So making a protocol, making a booklet, sending with the parents the booklet, asking them at regular interval with a reminder. That's our commitment to call them and to ensure that things will go well. That's probably message goes well to the students, probably all the trainees and the practitioners. Probably it will be helpful for the community and the parents. And such a small 30-minute session you covered. I have listened you so many years and so many times. The same 30 minutes you covered whole workshops program. So, but I will request all the fellows, whenever you will get an opportunity, if you start practicing, implementing this blue book, simultaneously, if a 1 day's program, if somebody will get an opportunity and you're interested for learning, you participate in that workshop of 1 day, so that you will get exposure to different tools and how to optimize, how to use in your unit. And before taking some questions, sir, you covered everything. I will again summarize 2 or 3 lines. As a pediatrician neonatologist, as SR told, anthropometry measurement for the growth and equally developmental. All the visits, including vaccine or non-vaccine visits, we should document in our case sheets when OPD we are seeing a baby. That gives us the growth as a length and the weight. That also gives us idea about nutrition and potential of the baby's growth and potential of the indirectly the brain growth by head circumference and length. So we'll get an idea of nutrition and growth. We should not miss it, which we can do without investment. And beyond that, if I'll say 3 important things we shouldn't miss beyond the development, neurodevelopment is a specific area. But as a pediatrician, when we are talking about another NICU has discharged at-risk babies, a small baby. He came to us as a pediatrician. At least we can ask, thyroid done or not? If not done, can we do it? The new hearing assessment done or not? If not done, can we optimize it? A eye test advised or not? If missed by somebody, by the parents or by the advisor, then we can reinforce. Can we do a eye test? If this basic thing as a pediatrician also we can do, the eye, hearing, and the eye test and thyroid and head circumference monitoring, probably 40 to 50% things we are covering, and nutrition optimization and further care, and the follow-up later will help us. So these are 4 or 5 things we probably, I think, we shouldn't miss it, because thyroid is a correctable issue, hearing is a correctable issue, eye test and giving a simple lens is a correctable issue. These are 3 correctable issues along with the monitoring of the nutrition and optimization of the feeding. That's probably a lot of help sometimes at-risk babies. And with that, probably we will try to take whatever the questions comes in the meantime. So somebody is from beginning, Dr. Mehek Manjal. So she asked actually why HMF stopped at discharge. Sometimes babies are discharged at low weight, means probably 1.4 or 1.5 kilo majority hospital at 34 to 30 weeks or 4 weeks or 35 weeks of PMA, we discharge. So should we stop there or should we continue? And if you're not asking to continue, do you have a concern, sir? That's probably her question.
It's a genuine question, because protocols for continuing HMF vary across the world. There are genuine, what you asked is correct. Many people have wondered that does nutrition become less important after discharge? In fact, babies grow faster and they may need more. When we wrote our blue book, we had a intention that babies should be directly breastfeeding than mothers pumping and feeding. And that is why when babies are ready to go home, either they are on direct breastfeeding mostly. And that was the reason for writing that you stop HMF. But I think it would be adaptable and variable between baby to baby. So there is really nothing that HMF cannot go home with the family. In babies who are not growing well, babies who may need more protein, a lot of science is happening in that area. Your question is correct. But this is just adaptation of the protocols. Regarding the growth chart choices, I think instead of choosing the growth chart, you may have to make sure you are plotting the growth chart. Whether use IAP, WHO, but make sure using a growth chart which is specific to preterm babies. We have shortage of time, but I can tell you in one line, preterm babies may grow their heads faster. And we had a baby who accidentally had the growth chart being plotted on a term growth chart, and they found that the head is going higher up in the line. They referred for ultrasound. Radiologist said mild ventriculomegaly. They referred to neurosurgeon. Neurosurgeon said, if you say there is head growing, we will take up for VP shunt. So the family came to us. It was a nurse mother. And it was very difficult for us to convince that we can't blame the other institution for using a wrong growth chart. That baby's growth head is growing normally, actually. And all others are probably being doing defensive medicine. So then we plotted on the normal growth chart for at least 3-4 weeks to convince her that your baby doesn't require a neurosurgery. So please remember the choice should be of a growth chart which is specific to preterm babies. So it can be any of them. There are differences, but I won't be able to discuss that in this one given time.
Sir, interesting question came. There's this question. If you want to take the question, BLW extemporatum, BLW neonate vaccination, I will just request you, sir, to little bit your favorite cocoon vaccination policy for the family. You just can introduce, sir. This will help actually. We are practicing in India probably few units only, cocooning of the family vaccination, but that concept will help a lot of trainees.
So there are two things that our own student Hema published her first paper, where we showed that vaccinating a preterm baby with BCG as soon as the baby is ready to go home and hepatitis B, or if the baby completes 8 weeks, even if he's on HFNC, he can get these vaccinations. But you will find details in the chapter in Cloharty. We added a new chapter in Cloharty called vaccination, which was never there. Very ironical, but Cloharty never had a chapter on vaccination. So vaccinations chapter has been added. You can get all the details. But cocoon vaccination is an important aspect. We used to keep getting babies back with pertussoid infections, with flu influenza, in fact, getting re-ventilated for 2-3 weeks sometimes. And therefore, we have started vaccinating parents and grandparents, caretakers who would take care of the baby after they go home, so that they will be at lower risk of getting infections from the family itself. So by the time the baby is medically stable and we feel that we can ensure survival at the end of 1 or 2 weeks, we ask the parents to take flu vaccination. We ask them to take DPT vaccination, and depending on their understanding, sometimes even varicella vaccination. So these are some vaccinations we ask them to take, and this is called cocoon vaccination. Similar concepts are being done in patients who are being taken care of, transplant patients, and it is definitely not yet a cost-effective strategy, but I think you cannot administer costing policies when a 24-weeker is going home and they have struggled for 4 months to get a baby.
So one interesting point I want to say here in cocoon vaccination, we were not practicing before, but probably many things we learned in the COVID era, and this thing also we learned in COVID era. The way we are speaking now, participating in the learning here, it was not common before. But COVID era taught us on how to connect by this Zoom meeting or Google Meet, and how to connect and teach and learn. Similar way, we learned this cocoon vaccination because we realized the family and care provider with the COVID vaccination done, these babies went home, the extreme prematurity baby. They not only vaccination, COVID vaccination, other simultaneously elder vaccines like pneumococcal and pertussis vaccines too. These babies came less actually, those 24 to 28 weeks baby. So with that time we implemented same time. The family care provider, we asked who are the grandparents or the parents who are the care provider to the baby. We started this influenza vaccination. Our influenza rate, we got adeno in this last season. Last year, adeno, lot of adenovirus we saw, respiratory illness. we did not have any answer, but we definitely saw, because we are testing all the babies who came back for admission, we're testing 3 viruses: RSV, flu, and adeno. It is available in our facilities. But we saw specifically the influenza rate came down drastically. We got few of the RSV, few adeno, but influenza came down. And that's probably with our implementation policy possible. We did not compare the data, but I will say from my experience, we used last few years, we got less influenza in those babies, of small babies with seasonal flu. We thought flu, we came back, and they got adeno positive and RSV positive, not the flu virus positive, because of the family and care provider received the flu. That started from this COVID era, because palizumab for the RSV prophylaxis is not very common in India because of the cost issue. But as are suggesting, pertussis and influenza, if we can give Tdap and influenza to the family members who are going to give care to the baby, these are two important infections we can prevent over. And sir, BCG is over. So now, sir, I will just extend the question a little bit. If the corrected age or chronological age, the chronological age wise 2 months or 6 weeks I am discharging. So should I consider to give all the killed vaccine, including either 6 vaccines, whole cell or cellular, or the pneumococcal, should give at discharge and send them home? Should I consider that? Because if the baby is already 8 weeks chronological age at hospital, I'm discharging, can I administer everything and send? Not the birth vaccine, because birth vaccine, hepatitis B and polio will be covered if I'll go for 6 hexavalent vaccines. Should I do that? Just this is not very development thing, but the start is extending such discussion.
We are vaccinating them, Nalini, and the what is called as adverse event rate was 12%. When in the terms of getting transient hypoxic events again. But this included all babies only less than 30 weeks. And among them, none of the babies got intubated, none of them got CPAP or FHFNC started if it was not there earlier. Few babies required caffeine restart. But though babies who had, was mostly babies who had been still oxygen dependent. So after that study, if the baby is oxygen dependent, we wait for 1 or 2 weeks more. So sometimes 8 weeks would become 10 weeks. But otherwise, if the baby is off oxygen, surely at 8 weeks, we would vaccinate the baby. What we do we don't have any scientific basis to do what we're doing. We vaccinate with, say, the pentavalent or hexavalent on first day and the pneumococcal on the next day. Our nurses feel that baby would suffer less, and therefore we do that. And somebody had asked about age of follow. It would be based on your logistics, but I think till the child enters school, that is when the first time the child is tested for his being completed and follow up. So do follow them for longer, and in a lighter vein, you will get more business also. So continue follow. It's for a commercial benefit also.
This question I was thinking to little bit break it different way. Neurodevelopmental follow, the hearing session follow, and the eye follow, sir. This is at-risk babies. If that I was thinking to break it and explain it, so that the eye follow-up, at least you have suggested 6 years or 5.5 years preschool age. You are in chart also, your eye follow-up you're doing. Hearing follow-up after Bera test at 3 months. If any concern, probably 18 months to 2 years. Some of the at-risk babies, meningitis babies, specific drugs may be received, or the exposed to high bilirubin and hypoxic babies, probably they might require a little longer follow-up and the hearing and speech follow-up. But the Bera, almost all the babies by 3rd month we complete ABR and Bera. So hearing that way to complete. And as SAR is showing the program up to 6 years, we can, the comprehensive follow-up, we can continue preschool age. Probably that will answer probably different sensory and motor, all assessment we can do with time. So this probably we end with all the questions, and vaccine related few questions we asked, and how till what age also we covered. So with this, if no more questions, and briefly probably this purpose of the session was there. If all the trainees during this neonatal acute neonatal training or neonatal training or training program, many times think of the acute care training is over, it's over. But probably this session again gives emphasis on not only the acute care and beyond the acute care, how to take care about the nutrition, and they're all comprehensive follow. So after discharge or after survival, we will get a better or intact survival later. That's why probably, or I think this is like will sensitize all of us. As a training time, we will sensitize today. Then tomorrow we will be practitioners, and tomorrow we'll lead some units where this practice directly can be implemented. That's the purpose of the session. Well, I thought this will give a input. And with this, all things probably, if no more questions, sir, we will close the session today. And before closing the session, I thank all the participants, their question, answer, interaction, or listening. And I will request with the group that PDF format we said in the NOEL group, as said by sir to me, and that is suggested by sir, you can implement in your units and you practice. Either you are practicing or in unit, you are in any unit, anywhere you can implement that. So that will be useful to the parents and the babies. It will help in directly or indirectly. Now you can use it today onwards. And with this, I'm going to close the session. And before closing, thank all the participants, and thank you, especially thank you, Navin sir. So such a 2 or 3 days back only I requested you, and you agreed, and you laid such a nice session where people can directly practice tomorrow. It is no need to learn and wait further, and tomorrow only they can practice these all the practice points, whatever you said with us, sir. Thank you again, sir. Thank you.
Good night, everybody.
Bye bye.
Happy
Bye
learning.
bye. Good night.
Bye.